Review Autoimmune Polyendocrine Syndrome. Introduction. Synonym: Autoimmune Polyendocrine Syndrome, Polyglandular Autoimmune Syndrome, PA, PGA, GAS, Polyglandular Autoimmune Disease, Polyglandular Failure Syndrome. Definition: coexistence of at least two endocrine gland insufficiency based on autoimmune mechanisms, association with non-endocrine autoimmune disease, two subtypes. Classification. Type I: Autoimmune Polyendocrine Syndrome, APST, Autoimmune Polyendocrinopathy, Candidiasis, Ectodermal Dystrophy. Clinical manifestation: persistent fungal infection, chronic mucocutaneous candidiasis, acquired hypoparathyroidism, adrenal failure. First clinical manifestation early in life, in infant, proceeding of skin candidiasis due to severe immunodeficiency, monogenic disorder, single gene mutation AR gene, autosomal recessive inheritance. Type 2 Autoimmune Polyendocrine Syndrome. Clinical manifestation: adrenal failure, Addison's disease, plus autoimmune thyroid disease with or without type 1 DM, adrenal failure, preceding other endocrinopathy, pernicious anemia due to autoantibody to intrinsic factor. Epidemiology: prevalence 1:20,000, female dominant, 3 times more than male, family member often affected, more common than type 1 PA, autosomal dominant inheritance, more complex polygenic disorder, associated with various HLA class I antigen, occur in adulthood, mainly 3rd-4th decade. Type 3 Autoimmune Polyendocrine Syndrome, thyroid autoimmunity plus other autoimmune endocrinopathy excluding Addison's disease or type 1 DM. Type 4 Autoimmune Polyendocrine Syndrome, 2 or more other organ-specific autoimmune disease. Consideration of variable combination of PA type 2. X-linked polyendocrinopathy, immune dysfunction and diarrhea, SPID, fulminant widespread autoimmunity in type 1 DM, developed in neonates, often fatal, FOXP3 gene mutation. Characteristics of PA. First disease manifestation in patients with PA2 endocrinology, July 2003, 88-7, 2983-2992. Most frequent disease combinations in patients with PA2 endocrinology, July 2003, 88-7, 2983-2992. Time interval between manifestation of first and second endocrine component diseases in 151 patients with PA2 endocrinology, July 2003, 88-7, 2983-2992. Immunopathogenesis: environmental activation. PI cell, peripheral Ag expressing cell. Environmental activation. Administration of IFN alpha pregnancy T cell depleting monoclonal AB. AR protein, stimulation of expression of peripheral Ag by cell. Stages and development of Addison's disease. Genetic susceptibility. APC type I, AR gene APC type 2, HLA drive, TQ. Precipitating event. Administration of IFN alpha pregnancy T cell depleting monoclonal AB. Assays for autoimmune marker. Autoantibody assay, disease marker in T cell mediated immune disorder. Autoantibody to the enzyme 21-hydroxylase, present in more than 90% of PTS with Addison's disease, almost preceding the onset of the disease. In case of no autoantibody with Addison's disease, evaluation of alternative causes, especially tuberculous adrenalitis. Autoantibody to TPO, TG, TSH receptor, autoimmune thyroid disease, Hashimoto thyroiditis or Graves' disease. Autoantibody to islet cell, GAD, IA2, insulin, type 1 DM. Autoantigens in patients with PA. Autoantibodies agents. Autoimmune disease. TPO, TG. Hashimoto thyroiditis. TSH receptor, TPO. Graves' disease. Calcium sensing receptor. Hypoparathyroidism. P450 cytochrome, 21O, 17O, SCC. Addison's disease. 17-0. Hypogonadism. Islet cell, GAD, IA2, insulin. Type 1 DM. H plus K plus 8 pace of the gastric parietal cells. Autoimmune gastritis. Intrinsic factor, gastric chief cell. Pernicious anemia. Transglutaminase, gliadin. Celiac disease. Cytochrome enzyme, P450D6, 2C9, P451A2. Autoimmune hepatitis. Tyrosine hydroxylase. Alopecia areata. Tyrosinase. Vitiligo. Management treatment, according to individual endocrine disorder. In case of Addison's disease with hypothyroidism, preceding glucocorticoid replacement, followed thyroid hormone supplement, enhanced steroid metabolism by thyroid hormone, precipitated hypotension and adrenal crisis by thyroid hormone. Screening recommendation. Requirement of high index of suspicion for additional autoimmune endocrinopathy. Patients with POT type 2 and their first relatives with isolated Addison disease or type 1 DM, periodically screening for the development of hypothyroidism, screening for autoantibodies against the thyroid. Absence of autoantibody, not exclude the disease, positive serology in not all patients. Requirement of long-term follow-up and observation, long-term interval between feared manifestation and further autoimmune endocrinopathy. Diagnostic screening for presence of PA. Functional screening. Baseline TSH, FSH, LH, free T4, testosterone, estradiol, fasting morning cortisol, and glucose. Serum Na, K, Ca, blood cell count. Optional, active stimulation test. Serological screening, autoantibodies to islet cells, gas, IA2, TPO, TSH receptor, cytochrome P450 enzymes, H plus K plus 8 pace of the parietal cells, intrinsic factor, transglutaminase, gliadin. Optional, genetic screening. Molecular analysis of their gene, especially for POT type I. HLA typing and subtyping.